All right, this is going to be the endocrine emergencies lecture. Hoping to do this in about an hour, so we'll shorten it up a little bit and speed through some of the slides. The endocrine chapter, I think, is pretty interesting. You do have to know it. Definitely, you'll need to focus on the sugar problems or the insulin problems, and then have a good, I guess you might say, working knowledge of the problems with thyroid and the adrenal cortex. The endocrine system influences a whole bunch of stuff. So a lot of people will think of the nervous system as like the hardwire system, and then the endocrine is more like your software. And I like that idea. For us, the big thing when we're talking about shock is the nervous system has this like boom, nerves go right to the different areas where we're talking about pupil dilation and faster heart rate, vasoconstriction, all of that stuff. And then it's supported with adrenaline as long as the nervous system is able to talk to the adrenal medulla. So we use an endocrine system to help us, just like with the nervous system, help us react to our environment and make sure that we're staying in homeostasis. When we talk about that negative feedback mechanism, the nervous system and the endocrine system work together to make sure that's working well. The two terms that we learn right away is this exocrine and endocrine. The endocrine, which we're talking about mostly today, is going to dump hormones into the bloodstream. If it's the exocrine system that we're talking about, the exocrine use their own ducts, so saliva ducts. When we talk about the pancreas, that's both endocrine and exocrine because it dumps insulin and glucagon and somatostatin into the bloodstream to work some endocrine stuff, but then it uses some duct work to release digestive enzymes down into the duodenum. And so here's just a kind of a, what would you say, satellite overview of all of the endocrine glands, at least the most important ones. First, we have the pituitary, known as the master gland. We're going to have to concentrate and learn these anterior and posterior pituitary. We have some upcoming slides for that. The next is this thyroid, and we're going to associate this with metabolism and our ability to manage our calcium levels. Here is the adrenal medulla and the adrenal cortex. And then we have the ovaries for the females and the testes for the males. Each of these we'll talk about more as we go along. So here's a little bit more about the way hormones work and our ability to adapt to our environment. Here it says hormones operate within a feedback system to maintain an optimal operating environment. So we've talked about these in the past. We have in the right side of the slide here, we see stress. As our body gets stressed, our sympathetic nervous system will be stimulated. The adrenal medulla will respond with epi in the bloodstream. At the same time, our nervous system is going to be taking care of the same kind of stuff, increasing respirations, increasing our chronotropic and inotropic properties of our heart. All of that kind of stuff will occur. Then the stress will stop and will decrease the amount of adrenaline, decrease the nervous stimulation, and we'll go back to normal. When we think about that, we've talked about negative feedback mechanisms quite a bit in the past, and we need to know these. You know, a great place to write in your notes then is you need to know all of the different negative feedback mechanisms. We talk a little bit about positive feedback mechanisms so far, which was the release of oxytocin during childbirth. But here we need to know that we have negative feedback mechanisms for the amount of CO2 in our system, which causes our respiratory rate to go up and down. We have baroreceptors, which give us a change in our blood pressure. We have thermoreceptors, we have osmoreceptors, all that give signals to the brain, and then the brain uses this nervous system and the endocrine system to make the changes that we need to make. So here is that pituitary gland hanging down from the hypothalamus. So we need to know all about the hypothalamus. It helps control all the body functions. We think about that as the thermostat for the body. It's also recognized as the switchboard for the brain. So all of the signals come up through here, and the hypothalamus basically says, all right, this is going over to this area of the brain, this is going to go over here, this is going to go over there. So as signals come up, boom, it goes through the hypothalamus, and that's the switchboard saying, all right, you're going here, you're going there. It also has complete control over the pituitary. And so here we see in the picture that the way we signal from the hypothalamus to the pituitary is different from the anterior to posterior. The anterior, we use hormones, which will either inhibit or excite, basically. We maybe call that a releasing hormone. The hypothalamus controls the anterior pituitary with hormones, and then the posterior pituitary, it controls that with the nervous system. Those are neurons there. And then we need to know all of the hormones associated with each one. So we can go to the next slide for that. Here we have TSH, that's the thyroid stimulating hormone. So that will be released, go down to thyroid, boom, and we will have increased release of that thyroxine, T3 and T4, and one of the ways that we control metabolism. When somebody has a slowed metabolism, and the first assessment that they have is they have a decreased amount of that T3 and T4, then after that, the endocrinologist has to go in and figure out, is it the thyroid gland that's broken, or is it that anterior lobe of the pituitary that's not keeping up with what it's supposed to do? ACTH is the adrenal cortex hormones, and then the gonadotropins is follicle stimulating hormone and the luteinizing hormone. Those two are important in the menstrual cycle. Then we see growth hormone, prolactin, and the melanocyte stimulating hormones. So for the posterior lobe, that one's where we should actually concentrate, is we need to know that ADH and oxytocin are released from there. And we have to remember the idea that if somebody is pregnant, having their baby, and we want to slow or make contractions less effective, if we give a bunch of fluid, that will decrease the anti-diuretic hormone, and at the same time decrease oxytocin, which is part of that positive feedback mechanism. As we decrease oxytocin, we will make the contractions start to spread apart more, last time, and be less efficient, basically. And here's a pretty good slide to look at all of the different things and what they do. Again, going from the anterior and posterior pituitary, they go to these different glands or different sites and cause, bone growth or whatever it would be. The pineal gland, you only need to know that that's where we secrete our melatonin, and it has a lot to do with our circadian rhythm. If we have a problem there due to trauma or a lack of blood flow or something like that, a tumor, your sleep cycle would be disrupted, wouldn't be as accurate, or what would you say, as efficient as it usually is. Thyroid gland, all about metabolism. We secrete calcitonin here, and calcitonin is going to lower your blood levels, put the calcium into the bone, is what I often say then. I think this would also cause you to pee out calcium. It basically lowers blood calcium levels. And the parathyroid is the opposite of that. The parathyroid is released when we have too little calcium, So we release this, and then we will start to, I like again to say, we can scrape it off the bone, or we can make it so the renal system does not pee out our calcium. So we increase the amount of calcium in our bloodstream. And so when we are little, we have a thymus gland. And thymus, big T there, it has a lot to do with the killer T cells, the helper T cells, the suppressor T cells. So we'll talk about this in the immune system a bit. Lymphocytes are T cells and B cells, a couple others though, but those are the big ones for us, T cells and B cells. And these T cells, especially when we're little, are assisted basically by the thymus gland. All right, and so we use the thymus then to identify and destroy some of the antigens. The adrenal glands, adrenal medulla and the adrenal cortex, you have to know the difference between those. Adrenal medulla is where we get epi and norepi, and we're pretty familiar with that. I think we've talked enough about that between shock and all of the pharmaceutics of that. And then the adrenal cortex, and so that's where we get our corticosteroids. So it is super important that we understand these things, because both of them easy to ask questions that can be somewhat confusing, because we can talk about it in physiology, pathophysiology, and pharmacology. And so those glucocorticoids, they do a bunch of different things. I think the first thing we should think about when we're thinking glucocorticoids or corticosteroids is the anti-inflammatory. All right, anti-inflammatory action of those. Probably that's boom, number one. That's why we give the drug usually is an anti-inflammatory action. But we should also see these other things, definitely quizzable and testable stuff. Glucocorticoids stimulate gluconeogenesis. We break that word down, just the med terminology of that. Gluco is going to be glucose, neo is new, and genesis is creation of. So we're creating new glucose molecules from something that isn't a glucose molecule or wasn't ever in its past. So it's you could also say from not a carb. We then with glucocorticoids we will mobilize amino acids and fatty acids. We'll inhibit insulin, so our blood sugar is going to be going up. Glucocorticoids cause blood sugar to go up, and then we get some vasoconstriction, and then it basically normalizes permeability. So again, when we talk about this, glucocorticoids aren't great when the person is having an infection problem, because during infections we want to have vasodilation and increased permeability so the white blood cells can escape the bloodstream and go fight the fight that they have to fight. It also reduces the white blood cell count. So all of those things together make it so when we give glucocorticoids, we reduce the patient's ability to fight an infection. Here are the different adrenal cortex hormones. So we have cortisol, a glucocorticoid, and that is going to increase your metabolic rate using fat and protein for energy. Aldosterone is the mineral corticoid, and that's going to reabsorb sodium. And so we know water follows sodium, so we won't pee as much when we're releasing aldosterone. The antidiuretic hormone and aldosterone, I think like molecularly, they look a lot alike. And then epi and norepi out of the adrenal medulla is going to give you your sympathetic nervous system stuff. Those again are recognized as catecholamines. Here then, just a little explanation of how this whole thing works. You probably get this already. When our body senses something, and here it looks like we are releasing some glucocorticoids ultimately. The hypothalamus will say, boom, I'm going to release a corticotropin releasing hormone. That's called CRH. That travels down through the bloodstream to the anterior pituitary, and the anterior pituitary is going to end up releasing that adrenocorticotropic hormone, ACTH. That was on an earlier slide. That goes down to the adrenal cortex, and the adrenal cortex releases the glucocorticoids. So all of these, then, if you were looking at a problem with releasing glucocorticoids on our patient, if we were an endocrinologist, we would have to look at, is it a hypothalamus problem, is it an anterior pituitary problem, or is it an adrenal cortex problem? Somewhere in there, we're not getting the hormones released. The pancreas, we have to know. The islets of Langerhans have alpha, beta, and delta cells, and those are going to release alpha will release glucagon, beta will do insulin, and delta will release your somatostatin. The next slide here covers what those will do. And you have to know all of these, all right? So we understand that insulin is excreted when we have higher blood sugar levels. It'll push sugar into the cell. And then here in the middle of that area, it says increases the conversion of glucose to glycogen. That's how we store glucose. And then glucagon is released when we have low levels. So that will basically travel over to the liver and cause glycogenolysis, which is going to be the breakdown of glycogen. And we'll have an increased amount of glucose in our bloodstream. And then somatostatin here, that middle one there, decreases insulin and glycogen secretion. So I think of that as kind of a reset for those. I think it's worth mentioning probably here is we also have acini tissue or acini cells in the pancreas, and those are the ones that release, that build and release the enzymes that help us with digestion. So here's testosterone, estrogen, progesterone. Very little we have to talk about right now for that. You know what testosterone is. And then estrogen and progesterone we'll talk about when we get to the gynecology chapter. Pretty much no quiz questions or test questions on either of these in Medical Emergencies 1. And so let's talk about some of the diseases here. I just skipped right over the diabetes stuff. So the diabetes stuff is already been covered, I think, really well enough in preparatory. You have to know all of that stuff. Know the difference between DKA and HHNK. And the big difference is DKA has an acidosis component to it. And DKA is going to be much more about that osmotic diuresis and dehydration, and the sugar is going to be a problem, but you'll also have electrolyte imbalances. So adrenal insufficiency and Addison's go together. So this is, for some reason, you're not producing enough cortisol and aldosterone. And so it's going to cause you to have some dehydration problems, an inability to maintain your blood pressure because you need all those electrolytes where they need to be, and you need to have fluid in your container. So if someone just has adrenal insufficiency, it is fairly well tolerated and somewhat easy to treat. Addison's disease is maybe the end of that then. Again, now we're getting some structure and function problems. And it occurs when about 90% of the adrenal cortex has been destroyed. Both the adrenal glands are atrophied. And so the things that we'll be looking at are hyperpigmentation of the skin, a low blood pressure, weakness, weight loss. You see under the GI there, nausea, vomiting, diarrhea, constipation. You can get both sides there, abdominal pain. And then when you're talking about an adrenal crisis, then we have fever, syncope, all the way to convulsions, hypoglycemia, and hyponatremia. All right, so if you're going to highlight stuff on this slide, it would be the low blood pressure, the hypoglycemia, and the hyponatremia. Those are the big ones. That's when when we kind of have to take action, which really is fluids and maybe giving them Solumedrol. Fatigue, anorexia, salt craving would be another one that that they would have, which kind of makes sense. Muscle and joint pain, and then that increased pigmentation. And here's yet another way to say the same thing. All right, this one has changes in the distribution of body hair, and then the GI disturbances we talked about. And again, we see there hyponatremia. With that can go hyperkalemia. So all of those, and that's Addison's. When we manage this, it's all about giving them fluid to support that blood pressure. Be mindful of the electrolyte imbalance, and hydrocortisone when we're in the crisis. The Cushing's is the excess cortisol production, all right? So it could be then the overuse of corticosteroids. Here, the blood glucose is going to rise. Protein synthesis is impaired, and the bones can become weaker. The signs and symptoms here, and I think of all of these when I think of Cushing's, it's fairly easy because they're kind of all the ones that, man, it seems like they are ones that if you were really vain, it would be like the worst disease in the world. They're all kind of the funny sounding ones, like a buffalo hump and thin-skinned, moon-faced. You end up with obesity, and then you get these abdominal striae, which are like purple stretch marks that are going up into your abdomen. You have poor wound healing, and that's all of these kind of make sense when when you go back to whoa, what did the hormones help us do? And when we have too much, what would that cause? We're not going to have good wound healing because we're not going to be able to vasodilate and get the white blood cells there. Not the white blood cells, but then the collagen and all of the stuff that we need to actually repair skin. Acne is another one that's associated with Cushing's. And then the management is pretty much supportive. Obtain a blood glucose and give them some dextrose if you need it. Pheochromocytoma is that excess epi and norepi, and so pretty easy again. It's just going to cause your heart to race and your blood pressure to go whack when you're not expecting it. So thyroid is next, and here your thyroid goes up and down, and it's associated with your metabolism. And all of these then kind of make sense when you have hypothyroidism, which is a very common thing as people get older. I think it's really associated with older females. We'll have a slowed metabolism. So you're going to have a slow pulse, reduced cardiac output. Easy to gain weight then, and you have a cold intolerance. You're just kind of cold. It can go all the way to where you're hypothermic. Sluggish, weak, slow reflexes, constipated. And then hyperthyroid on the other side is going to be just the opposite, all right? You have increased metabolism, so you can be hot and flushed. Weight loss will be the concern instead of gaining weight. Graves' disease is when you've had hyperthyroid over a period of time. Now you've grown a goiter, and you can get exothalamus, where you have those bulging eyes. Thyrotoxicosis is when you have a big dump of the of those hormones, and you don't have to have the goiter. It doesn't have to be an autoimmune disorder, but it often is. But you get just this huge amount of the thyroxine, or T3 and T4, and all of a sudden your heart rate is 180. So it's going to be a lot of times when we're seeing this, we're thinking that it's just a SVT, and it's not going to respond to the way we want it to be. The patient will probably be in a fast sinus attack that will look like an SVT. And then that thyroid storm is the same thing. We can call that thyrotoxicosis and the thyroid storm. Boom, we would call them the same thing. We wouldn't differentiate them. Myxedema is structure and function problems after a longer period of low thyroid. In here it says it presents with that mucinous material of the skin. I think we described this as orange peel skin. It slows all the metabolic processes, so fatigue, feeling cold, dry skin, possibly hypothermic. And it can go all the way to where they're in a coma. Often it's precipitated by triggers that cause something to get worse in the patient, like a trauma or a bad sickness, COVID probably. And then our treatment is going to be oxygen and treat what we see, keep them warm, and that's it. Diabetes insipidus is the last thing to talk about, and this one's pretty easy. It's the lack of that antidiuretic hormone. So if we don't have an antidiuretic, what we're going to do is pee too much. And so it could be the kidney side of it, it could be the ADH side of it, and it could be, again, the hypothalamus side of it. But for some reason, we're not dealing with our ability to keep our urine inside us, basically, keep our fluids inside us. So we're peeing too much. And to manage it, we just give ADH. So it's a fairly easy one. We don't have to manage it as paramedics, but it's pretty easy to manage for your internal medicine doc. And I think that will be it for the endocrine chapter. Again, best thing for you to do is just hit the A&P side of it. You can do the A&P chapter if you want and drill down on all of the HH and K stuff. You should know DKA pretty well. We don't need to know much more than EMTs know about DKA, since it's, given that we've talked about it so much in the preparatory because it is associated with the acid-base stuff. And I think that is it. Thanks.